Yes, thank you. I'm going to talk to you today about the work we've been doing in my my group, which is it has been the depth research group. So it's actually a program of work that we've been doing. It's not one project, but it was a series of projects over probably 15 years or so. So it's been quite a long time. So I'm not going to go through absolutely all the different things that we've done over that time, obviously, but I just wanted to, because we're kind of drawing it to a close now, it seemed like a good time to reflect on what we've learned, what kinds of things we're going to take forward, what the kind of questions remaining are, and then also just to share some of the things that we've been thinking about in the group. Right, so I thought I'd start with just a really simple one, which is why co-production. So obviously, it's kind of the flavour of the month now, and lots of people do it, so I'm not going to kind of assume that you don't know anything about it, but I just wanted to say that when I'm talking about co-production, I'm talking about collaborative working with academic and non-academic partners usually, but it could also be, I mean, I'm increasingly thinking that co-production is quite a useful way of looking at any kind of collaboration and just looking at the kind of knowledge that comes out of that collaborative working. But here I'm going to be talking about collaborations between academics and non-academic partners. So they would include people like policymakers and members of the public. And so on a really basic level, we can just say that the most complex problems in the world require a diverse group of experts to solve them. Like we can't solve any of the complex problems with just one set of expertise. And so in health in particular, the expertise that comes from living with a particular condition is particularly important. But obviously lots of people have their own particular insights that they can bring to bear. And obviously also in health, you can have the most brilliant technological solutions, like the best vaccine, the best contraceptive, the best kind of health promotion intervention. But if people won't use the method and they aren't interested in your intervention, it's going to have absolutely no impact whatsoever. And so I know this is stating the obvious, but it seems sometimes that there is a kind of like, oh, we've got it, we've got the drug, it's going to work, everyone's going to be, healthy and everyone's going to be fine. And then, or a vaccine for COVID. I mean, we all know what happened after that. So the idea is that you can kind of try to address some of these really complex problems. Try to even anticipate some of the complexities before they arise, rather than post hoc when it's too late. I mean, the kind of anti-vax thing for COVID vaccine was a rather predictable possible outcome. I'm not saying that it could have been prevented, but it's just the kind of thing that you have to take into account. So when we ask people to come into these kind of co-production spaces, we're asking them to work together, and we're often saying, look, we want you because you have this particular sort of expertise. But for members of the public, there's a question about what counts as expertise, and I'm just going to deviate very slightly because I'm slightly obsessed with this. So I'm going to subject you to my interest in what counts as expertise. And we did quite a lot of work as part of the depth work was with the Clerk for North West London, which is it stands for something, Collaboration for Learning and something. Anyway, it was about trying to get health research into practice in clinic settings, and it had this whole massive patient and public involvement component, so PPI component, which we were actually there to analyse and assess. And so as part of that work, it was ethnographic work. And as part of that work, we interviewed clinicians, we interviewed patients, we kind of spent a lot of time looking at what was going on with the collaboration. So this is what one of the clinicians told us. The only time that I've ever encountered anyone who was able to step outside of their own perspective was a woman. She was excellent. She was fairly intelligent to start off with. She was actually able to look at it from a kind of complex lay perspective, a perspective that's broader and more general. And one of the things that really stayed with me about this project was the way that patient expertise, so their own lived experience, their own subjectivity, was why they were invited into the spaces, but it was also denigrated once they were in those spaces, because the clinicians wanted something more general. They didn't want, your one experience. They wanted kind of the patient experience. And so patients were in this impossible position where they were trying to share their own stories, but the stories weren't really accepted as evidence, because it was like, well, it's just your story. You're biased. You've got a particular interest. And so it kind of put them in a position where they were both had this important knowledge and were prevented from sharing it. And so I raise this obviously because, and I would note that in those kind of collaborations, the only people who are sort of considered less appropriately involved through being inexpert. Sorry, hang on, I'm getting this thing tangled up. The people who are supposed to be inexpert are the patients. So everyone else is supposed to be an expert, and they're supposed to be like, they have all these different kind of qualifications, whereas the patients are actually supposed to be not qualified. Like if they're too qualified, then they're actually accused of being too qualified. So they're kind of in this position where they can't be expert in being a patient expert, because then they're considered not representative of the patients, but they also have to somehow know how to communicate with clinicians who won't accept their subjective experience. So it puts them in a very difficult position. And I heard people referring to patient involvees as the usual suspects in quite a denigrating way, which I think is quite an unacceptable way of treating someone who's a volunteer and trying to help with give their time. So, this is, and these are people who are usually retirees. They're often, middle class. They're used to boardrooms. They're happy to go along and talk to the surgeons and so on. So you don't necessarily get a wide range of people who are in those kind of roles, and that's one of the reasons why that is exactly these kinds of social kind of setups. Anyway, right, I'm really deviating from completely run over if I keep doing that. Right. So what counts as expertise? Well, one of the things that I've increasingly found a more useful way of looking at things is to look at community participation involvement as expert involvement. So we're talking about, people who are experts. They're coming in, and their expertise is what they hold. It's not that they can somehow speak for everybody, but that they have their own subjectivity and they're able to give comments on whatever it is. But you have to make sure that whatever the kind of dialogue is that you're trying to have, it's appropriate. That you're not expecting patients to be mini researchers, for instance, and then be annoyed that they can't follow the kind of complex academic language, whatever it is. And that's true in any community of experts. So in any collaboration, people can get lost without good dialogue and translation, and they may never even realize what it is that they've missed. So because co-production is collaborative, dialogue is essential. And here the dialogue can be between people at interview, between collaborators, between organizations, between researchers and members of the public, and so on. And dialogues are also necessary to avoid harms. So when you ensure that key people are involved at every stage, it will help make sure that the right type of research is done, money's not wasted, views of marginalised people aren't ignored, women's voices are included in all their diversity, findings are reported sensitively, and avoid stoking tensions or reinforcing harmful stereotypes. And the additional nuance that you can get in those conversations will help avoid jumping to overly simplistic conclusions. And the other thing about dialogue is that when we engage in dialogue, we're much more likely to find out what we don't even know we don't know. So we're more likely to then be kind of aware of areas where we hadn't even thought to ask the questions in the first place. So for me, dialogue is at the heart of meaningful community participation and the collaborative relationships that we need to solve complex public health problems. And so working out how to achieve it is or should be a fundamental concern. So the question is how you actually put this into practice. Like, it's all very well in theory. We need effective translation, and particularly in very diverse teams. As academic researchers, we need to be able to speak to each other and understand what disciplines outside of our own can offer. And we also need to try and get teams working together effectively. And although you might not, well, it's not usually considered translation, but I do see my role often as being a translator between different team members because of the different disciplines that are involved or different backgrounds of the people that are in the team. So even with academic teams, that's true. And then once you start adding policymakers, members of communities, it can become completely chaotic if you don't have a good way of communicating between you all. And in my work, because of the diverse teams I work in and manage, I've had to think a lot about translation. And anyway, I'm obsessed with translation, so it's quite convenient that I can bring it into this too. But there are these different forms of translation that I've written on the slide, but almost none of them are really thought about particularly carefully, and certainly in the public health world. And it's not usually an object of inquiry, the actual translation part. So I neglected to say at the beginning that I was going through the acronym of DEPT, which is Dialogue, Evidence, Participation and Translation for Health. So we've already done dialogue, we've done translation. Participation is a bit of a cheat because I've turned it into co-production, because since we made the acronym, I think the P doesn't work so well anymore, but it would have to be C, and then it would be DEC. So I'm keeping the P for the moment. But anyway, so and then the E is for evidence, and obviously that's the kind of business that we're in, research is generating and synthesizing and understanding evidence. So here's some of the stuff that the DEC team and I have been doing over the last few years. So they fall into the categories that I've put there, which is sort of slightly overly simplistic, but all of the work really is intended to inform policy and practice. So it's there even if it's not directly to inform, even if it's not directly to generate policy and practice recommendations. It's there with a view to improving health, for instance. And then also we've done a whole load of methodological development for complex intervention evaluation and evidence synthesis. And we've looked also at getting evidence use into global guidelines, so improving evidence use for global guidelines. And I've done quite a lot of work with WHO looking at, for instance, including qualitative evidence in guideline development. And I've also done a lot of work with WHO on actually guidelines for participatory intervention recommendations. So looking at what sort of evidence you need to be able to make a global recommendation for participatory interventions. Anyway, so that's by way of kind of just a bit of background for the next part, because one of the things that and I should mention the Access Consortium. So this is one of the more recent ones. It was a £21 million consortium that we designed to use participatory approaches to improve sexual and reproductive health and rights in what we call complex and challenging environments, which included humanitarian settings, but weren't limited to humanitarian settings. And that was the partners were spread across 4 different continents. And Access did give us a chance to think really carefully about what it means to do participatory work, what kinds of evaluation techniques we can use because the partners were actually doing the interventions, and so on and so forth. Now, during Access, I found that it was incredibly difficult to communicate research ideas to the kind of diverse teams that we were working with. And one of the things I discovered was that I had to use a lot of diagrams. And so now I use a lot of diagrams. I'm going to show you one in a minute. But I just mentioned that because it's another form of translation, which I hadn't considered at all until I just could not get the ideas across. And then as soon as I started drawing them, I mean, I'm not talking about anything sophisticated. You'll see in a minute, it's very unsophisticated. But as soon as they were on the page as a kind of visual, it just meant that people could follow what I was talking about. So anyway, just if you're ever in that position, I recommend trying that. Now, unfortunately, Access was cut without warning in the 2021 aid cuts. And so we never finished the work, which is a real shame. And I also had to learn a lot more than I would have ever chosen about crisis management. But anyway, so over the course of all these different projects, and particularly during Access, when we were thinking about it in detail, we articulated what we've called the depth approach, which I will show you. We can express as a diagram. So it's a 6-step approach. Do you like it? It looks nicer than text, just text on its own as well. Anyway, so I mean, this was it like all the diagrams. The idea is to make them as simple as possible. And obviously, when you make things simple, you strip out a lot of the kind of complexities and interrelationships. But what I've found is that when you show people the diagram, they can kind of get the general idea of what you want to do, and then you can start introducing, oh, well, actually, you know, it looks like that step always comes after that step, but in reality, sometimes there's a bit of back and forth, and then people seem to be quite happy with that. They don't seem to mind at all, as long as they can kind of follow on the step. Now, I'm going to show you a kind of case study for each step so that you can see rather than just the abstract. But just to say, the idea of this was to embed the research into the co-production rather than the other way around. So this was our sort of solution, if you like, to that. So this is the case study is one that we did very recently. It's called Roots. and we were working with Gypsy, Roma and traveller communities. This is in England, and migrant workers in precarious jobs also in England. And it was a rapid piece of work funded by the Department of Health and Social Care through NIHR. And my co-PI, I should say also, the depth approach and this project have also I've co-developed them with Alicia Renedo, who's also at the school. She's an associate professor at the London School of Hygiene. It was a co-produced qualitative piece of work. It started off, there was a call for proposals for, I can't remember exactly what the funders wanted, but we sort of went in and said, oh no, but what you want is not going to work for these reasons, and what you need is a much more expensive project for these reasons, and it has to be co-produced for these reasons. And the funder actually, rather surprisingly, did actually agree to pay quite a lot more money. But the reason we particularly wanted it to be co-produced was because of the marginalised nature of the communities that we were going to be working with, and we were very well aware that researchers can cause harm, and we didn't want to go in and make things worse for people. Right, so I'll show you the kind of steps. So the steps of the depth approach I'll show you with relation to this particular programme, so you can see what we did. So first we had this sort of mapping scoping phase, and in that we basically were trying to work out who we needed to contact, who were the kind of key players, who we would ideally like to involve if we can. We obviously did literature review. We talked to everyone that we could find, and then we asked them to suggest more people to talk to. And so this all happened, all this was in a rapid project, but we still managed to get 32 people that we spoke to, who kind of basically gave us a kind of sense of what was happening, where we were with, it was even more complicated because it was large numbers of different communities that we were trying to incorporate, with migrant workers included, as well as Gypsy, Roma and traveller communities. Anyway, once we'd sort of got a sense of who the important people were, or who the organisations were that we really needed to have involved, we asked everybody if they wanted to participate. And part of it, we weren't really expecting everyone to say yes. In fact, lots of people didn't say yes, but we wanted to make sure that they felt that they had been able to participate. So if they saw that the research was coming out, they would be like, oh yeah, I remember someone talked to me about that, and they would maybe look it up, or and they wouldn't feel like, why haven't they approached us? Because there can be quite a lot of what's the word? You don't want people to feel like they're not important enough to be involved. If it was just a mistake that you didn't, you don't want to kind of, for people to feel that they're excluded. I mean, mainly the problem is getting people to do it, but anyway, so once we'd done that, we asked a lot of people if they wanted to get involved in dialogues. That was the phase 1 dialogues. This is the second step. For this project, we had 8 informal dialogue sessions. We sometimes have a bigger sort of launch event or something like that. For this one, it wasn't going to work, partly because of COVID, partly because of the nature of the populations. We wanted to make sure that we were going to where people were, rather than making them come to us. And so particularly for the Gypsy, Roma and traveller participants, there was a real emphasis on being there in person, being seen on the traveller sites, making sure that people could sort of interact directly. So there was no chance of doing online meetings. We thought to start with we might be able to do sort of Zoom or something. It just didn't work at all. And then online we did manage to involve academic researchers, civil society organisations, and obviously not obviously, but the Department of Health and Social Care staff who'd commissioned the work. And so we had very regular online meetings with the test and trace teams, and quite random other people that would come to the meetings and would never introduce themselves. So I have literally no idea who they were. But anyway, they all seemed to be in policy one way or another. And which was nice, actually, because there were a lot of people, suddenly loads of people would turn up to these online meetings, and we were kind of, delivering findings as we were going along. And so, at least we thought, well, people hopefully are going to be able to put them into practice immediately. And just to say, we also identified in the first mapping phase, and as we went along, actually, community co-researchers. And for all our projects now, we have co-researchers. And these are people from the communities that are affected by the work. In this case, it was people from Gypsy, Roma and traveller communities and migrant workers. And We pay them. I think that's why I put paid in the title. It's really important that they're paid. From our other work, there was so much discussion about why all the medical staff paid and we're not paid. We're volunteers. We're expected to come here. We're lucky if they pay our travel. So we were just really clear that we pay per the used to be the Involve guidelines. I think it's just called NHS participation guidelines now. So they have quite clear payment sort of structure which we follow. And if it's not clear for our project, we make it clear to the participants. They know what they're signing up for. And in this project, they helped us refine our approach. So, what are we doing? Where are we going? They helped us kind of understand that we had to do it all in person especially for the traveller communities. They did some of the interviews. They helped facilitate dialogue sessions. They recruited. Recruitment for interviews was really, really important. They did a lot of work to get people to come and talk to us. And then they were also invited to interpret findings and contribute to the dissemination strategy. So they were basically working with us throughout. Then we had the data generation, which is more like your traditional academic research project part. So we did qualitative interviews, we did fieldwork observations, we had these dialogues, which you can kind of count as focus groups. So yeah, so for the interviews, I've put what on the slide, who we interviewed. We were supposed to get a spread across the whole of England. And this was, by the way, a contract that I think was signed in maybe July. And then they were expecting the first findings in September. So it was quite difficult. So yeah, we didn't manage to get very many people in the north but we did have a reasonable spread across the kind of South and Midlands areas. And that was largely because of well, anyway, I can talk about how we managed to recruit anybody at all, but it was, we had existing networks. So a really important part of our work was that on our research team, we had recruited for this project 2 people that we'd worked with before. One who had expertise in Roma health and had worked with Roma communities in Romania, but also had lots of good contacts in the UK. And then also we had a researcher who was herself from a traveller background. And so that meant that we were immediately networked into a lot of communities where otherwise it would have been completely impossible to, especially at short notice, to go and get people involved. And then we did the preliminary analysis. So I'm going back to this thing about expertise. One of the things that we've been trying to work out is how to include people in ways that actually work for them. And so for me, it's quite important to have this preliminary analysis phase, which is basically like, the academic team then kind of more or less goes off by themselves. I mean, it doesn't have to be completely on their own, but there's no expectation that our kind of co-research is going to be slogging through transcripts or, data, whatever. And that, the idea is that we would do all that and then bring it back to the bigger group. And so the preliminary analysis is done in a way that, it's stated to be preliminary, and we bring it in and we say, look, if we've got this wrong, if this doesn't ring true with you, or if we're missing a really important point, then this is, you can raise it. So we take it back to these dialogues. And sometimes it's the same people in the second phase of dialogue. Sometimes it's new people. Sort of depends who's interested, depends who's available. But the idea is to kind of check in with all of the key stakeholders and make sure that it makes sense to them. For the policymakers, it might be, is this actually useful, or do you need information about some other thing? I mean, one of the things that the policymakers asked us for were, in one of the dialogue sessions, we had asked, well, we weren't going to ask, but they had asked us, can you find out what people would like to happen to improve the COVID response? So, for testing, contact tracing, and vaccinations. And so we just went and used some of the dialogue sessions to just literally just ask people, well, what would you do differently? And then we were going to collate it and kind of get it all together, but they were actually quite happy to have them written up just as they were in a list. So I was quite surprised by that. But anyway, that was apparently useful. But all of that was possible because we were talking to all of the different participants throughout. So we could, when the policymaker said, well, didn't you ask them about this? No, because you never asked us to. We were able to go back and ask later and just say, okay, well, we didn't realize that we would need to do this. But so it made it much more flexible, and it meant that everybody hopefully got what they needed out of the whole thing. It's really, really hard to do co-production work in an academic institution, or at least that's what we have found. And I don't know if any of you have tried it and whether you've also found it difficult, but there are a lot of things that need to happen for a co-production project that are not necessarily set up very well in most institutions. So one of the things that we didn't have was the ability to pay people in cash. So we would pay people a small amount for participating in interviews. We would pay the co-researchers, but for some people in some of the communities, they only wanted cash. So we would usually use vouchers for projects. They didn't want vouchers for various reasons, which I can go into. And they certainly didn't have bank accounts, so we couldn't just be, it was like, well, why don't you just get their bank details? It's like, well, first of all, they want to be anonymous. Secondly, they don't have a bank account. And of course, that it's an issue that arises with research on violence as well. If you're in a financially abusive relationship, for instance, you might well need cash rather than some other form of payment. Anyway, there were also a lot of things that we had to produce, which then we were able to transfer over to other projects. But for instance, co-researcher training modules, so that people know what they're supposed to be doing. Field worker safety procedures, we have our own, because the ways that we work are maybe a bit different from some, so we borrow from other people, but we have our own safety procedures, ethics, which is already raised, and governance, and things like data protection. How are people who are interviewing going to manage the recordings of the interviews in a way that complies with GDPR and ethical kind of confidentiality type stuff? Anyway, so there's an awful lot of background stuff that goes into making sure these things run smoothly. And I partly raise it because I think it's underestimated a lot, and people sort of just plow on and sort of then have to do it. We had to do it as we were going along the first few times. The inclusive ethos is, it kind of is obvious really, but you can't really have a good co-production space if people don't feel welcomed into it, or if there's kind of conflict between the people in that space. And it's not straightforward. You're bringing people together who are absolutely never together normally, and sometimes it can be quite challenging, to say the least. And especially the challenge often comes from the minoritized people towards the people who are they perceive as maybe not understanding what their situation is, and so on. And so it can be quite it's important to make sure that that's kind of understood, and that there are ground rules, and that there's a way of kind of handling it. And again, like for me, that my role was often just talking to everybody and trying to kind of, I don't know, bring peace, which usually worked fine, because usually there was a misunderstanding that it was possible to draw out and understand what it was. But yeah, it was a lot of work. And again, it's not something that you can underestimate. And then the final thing is flexibility from funders. We've had both. We've had both flexible funders who are amazing, and we've also had inflexible funders who've caused us huge amounts of problems. And I can talk more about that later. but it's very hard in a co-produced piece of work to predict in advance exactly what is going to be needed at any given time. So a bit of flexibility makes a huge difference. Even if the amount of money is the same, being allowed to change how it's spent has a huge impact on the kind of overall success of the project. Right, so the final step, if you like, of the approach is what we call research into action. And actually, we were talking earlier about what happens at the end of a project. And so this kind of speaks to that a bit, but I don't sort of fully answer it, I don't think. So at the end of the project, obviously, as an academic team, we would want to produce academic journal articles. I've put sort of slightly tongue-in-cheek, internationally excellent journal articles, but not entirely tongue-in-cheek, because first of all, we have to write them, otherwise we lose our jobs. And secondly, actually, I think that we have kind of an ethical obligation also to make sure that the work that we do is a high standard. If we're asking people from communities to give up their time, especially marginalized communities whose voices are often ignored, the least we can do is try and do the best possible work that's then given credibility by being published in the best possible journals, because people can use them for advocacy. They sort of go, look, this was published in, and they understand from working with the academic teams that these journal titles have currency in and of themselves. And of course, well, not of course, but the other really awful thing is that, I've often said to people, look, we're basically saying back what you've just said to us. This is the paper. It just says the same thing you've already told us. And it feels a bit embarrassing to kind of go, well, but the kind of power of it being in a paper is quite different from, it sort of feels slightly like, well, doesn't everybody already know this? But it is useful for people to have their words kind of authorized almost. And we've also, because of the way that sometimes it's not just that they're telling us things and we're reporting them, but they're actually involved in the analysis to the extent that they have given us substantive contributions to the actual paper itself. And when that happened, the first time it happened, I thought, well, if an academic colleague had done that, they would be entitled to authorship because, it's made a big difference how we see the whole paper. So then we tried to work out how we can make sure that we can give people credit for input if it comes to sort of an academic authorship sort of standard. Anyway, so we did a whole massive piece of work specifically on authorship, which if you're interested, you can read. There's the paper that's referenced in the corner. And it's work that's ongoing. I mean, it's not straightforward. And because we have a no gift authorship policy on my team, it has to be real. Like, you can't just say, oh, you can be an author on the paper, we'll just like put your name on. That's not at all how it goes, because that's not fair on junior researchers who get left off papers, and it's not fair on anybody to put people on that haven't done the kind of contribution that's required. So we tried to think through what contribution is required from non-academics in a co-production process, and that's what that paper's about, and are thinking about it. So anyway, so the journal articles are one thing. We do all the usual sort of stuff. We did some regular meetings with key stakeholders, Q&As with policymakers, informal updates. And then we also, for most of our work, we've done outputs for non-specialists, because again, it's that thing about, well, what, we came in and we worked with you, and then what? We've given you these incomprehensible journal articles that nobody cares about, or if they do, they're unusual. I mean, actually, a surprising number of people do read them and like them, which is has been quite nice, really. But also we try to make sure that if people don't want to read the whole thing, that there's something available for them to just get well, we've called them lay summaries. So like an abstract, but written in language that's not overly complex. So we've got those on our website. They're a bit, the key person that used to do them has left, so they're a bit out of date. But the ones that we have got are there, and you can see if you're interested to look at them. We also used to have a very active social media presence. We did quite a lot of engagement with communities and civil society organisations. So, for instance, we did a project about sickle cell. We worked with, after the sort of research part was over, we worked with the Sickle Cell Society on a campaign that they were doing, and they wanted to use the findings from our research to inform their campaign. So we talked to them about their kind of campaign strategy, and I mean, not that we know much about campaigning, but they wanted to kind of talk to us about the research in that context. So that was really nice to see. And the idea of research into action for us is that this is the point where we all collaborate where we can, but we also go off in our separate ways. Like, we'll happily work with an organization on their campaign, but we're not going to do the campaign. We're not going to get money for the campaign to happen, because we're not the right people. Now, we might help that, but we're not the people to actually do it. And so we try to make it really clear at the beginning as well, the kind of almost like the obligations of the participants. Like, this is your job now. It's to we've done our research bit, we tried to make it available and accessible, and we can work with you on understanding it, but now it's your job to take it out into the world, and whatever you want to do with it, you can do with it. So we've seen a real sense of ownership of the research that's come out of these kind of processes, which has been so nice. People really, especially when they've been an author on the paper, they've really felt that they can talk about the research, they can bring it to different fora, they can send it around professional networks. Patient representatives anyway are really good at being in different spaces and linking them up, and so they also take the research around and just make sure that everybody's aware of it. And the other thing that has been, so the community-led dissemination of findings was a bit unexpected the first time it happened to us. We didn't really realise that might happen, but people really liked being part of the thing, and then they just were telling everybody. So that was great. And so now it's kind of built in, like, we kind of think that this will probably happen. And then the authorship I've already talked about. So the final thing is this thing about new scholars. So again, it's sort of, I suppose we could have predicted it if we'd thought about it, but the kinds of people that come into our team as co-researchers, obviously, often have an interest in research. Like they're not only doing it because they get not a huge amount of money, but they're actually genuinely interested in the area. And sometimes we've recruited them because they're already working as advocates or something like that. But we've also found that people, having been part of the team, will then apply for kind of funding or fellowships, that kind of thing, to go into to get a qualification like maybe a master's or a degree. So from not having that level of qualification. And so I'm actually really interested in what that means in terms of alternative entry into academia, because obviously there's a huge underrepresentation of people particularly from marginalized communities. And they are coming through these kinds of processes. So if there are more of the kind of processes, we might find that there are more opportunities or more people that can kind of come through those routes into what have otherwise been quite inaccessible places for them, or uninviting, or not of interest, or whatever it is. Right, so I'm not going to go through partly because of time, but I'm not going to go through the findings of the roots for a project as such, because it's sort of it was more kind of supposed to be a case study. But just in case you're interested, what we found was that the formal COVID response was rather inadequate for these communities in particular, because the testing, for instance, they didn't want to report back the results into the government system because they didn't trust the government to take care of their data. They didn't want to engage with contact tracing for the same reason. They didn't think it was the business of the contact tracer who they'd been with and when. There are also barriers to basic communication, low literacy, digital exclusion on, in some traveller sites, there just wasn't any 4G or whatever. English language skills for the migrant workers were sometimes not good enough to understand the information, for instance, about testing, back in the day when nobody knew how to test and swab, and you had to look at those really complicated instruction booklets. Anyway, and then, well, especially within the traveller communities, there were these kind of mutual aid and support networks that came up. So instead of, and particularly once the lateral flow tests were available and people could test themselves, and they were free at the point of collection, and so people would know if they were positive for COVID, but then they would do their own contact tracing and support. So they would report into their own networks who had COVID, and they would say, well, you've got to watch out for, people in this caravan have got COVID, so don't go too near. They put, like in some sites, they put notices on the caravan door to warn people not to come too close. And basically, in some cases, they're putting on Facebook that they've got COVID, so people would kind of know, and they could kind of do the contact tracing in that way. So, and they also did their best the self-isolation was so difficult for the travellers living in cramped caravans. I mean, really, really hard. One woman told us that she had gone to bed with her husband and she was wearing a mask because she was positive and she didn't want to infect him, but they didn't have a way of isolating from one another. So, and this is all in the context of a much wider oppressive sort of environment. So the hostile environment, obviously, for the migrant workers, the police crime sentencing and courts bill for the travellers, which seeks to basically criminalise a kind of migratory way of life. The poverty and the precarity, which I already alluded to. It's much harder to stay safe if you don't have much space. If in your workplace for the migrant workers, their workplaces are often unsafe for COVID. And generally the poor infrastructure that people were living with. So a lot of travellers were also carers. They told us about caring for elderly relatives, caring for people with disabilities, caring for newborn babies. But they were also on sites which didn't have very good facilities. And in lockdowns, they were particularly left kind of without support. So, for instance, one person there was a dispute with the council about planning permissions, and the water had been cut off to the site that she was living on. And so she told us, we've been told to wash our hands. The safe thing to do is keep washing your hands. We didn't have the water to do it. What I used to do is I'd keep a bucket of water at the door and pour 3 cupfuls of Dettol in it and leave a towel on the bench. And what I used to do was, even when the kids were going out, dip your hands in the bucket, wipe. Anytime they were going back in, dip your hands in the bucket, wipe. They had no skin left. Yeah, so this is water being cut off, in a lockdown where obviously one would hope that people would be able to keep clean. So these are the kinds of structural issues that the interviewees were having to deal with. So we wrote some papers, which there's one we wrote about vaccine hesitancy and pointed out that it's in historically marginalized groups, looking at a kind of an individual decision-making way of understanding vaccine uptake isn't very helpful. Even our interviewees who had a vaccine dose often said they felt coerced into it. So for instance, they needed to, for the Roma interviewees particularly, they wanted to travel to see their family, and traveling is a really important thing for them, and they couldn't travel without a vaccine certificate, so they felt they didn't have a choice, and so on. Anyway, we also looked at how key workers tried to reduce their infection risks, and the ways that they experience the spaces of their unsafe workplaces extending into their domestic spaces, and trying to kind of develop their own measures to reduce the chance of bringing COVID into their households, mostly without support. And that was the same with the travellers, actually. Where there were like shared toilet blocks and things like that, they didn't have any advice on how to reduce the risk of infecting one another, and it just wasn't provided to them. It would have been something that would have been quite easy to advise them on. So overall, we found that there were community-led solutions that developed to fill gaps in the public health response, but they weren't supported. So, people were trying their best to avoid infection and so on and so forth, but they weren't being given the advice they needed. And there was a suspicion anyway of the healthcare services, which they'd had bad experiences with in the past. One of the things is obviously we just need to make sure that for emergency preparedness, we're kind of considering that COVID's sort of basically over at the moment, which is possibly not quite correct. But there doesn't seem to be much move to prepare for the next emergency, and there will be one. And so one of the things that we've also been looking at is how to kind of advise on preparedness and for future emergency responses. And so with that in mind, this is a very, very quick run through a piece of work that we did in the pandemic. This was I think we published it in August 2020, because we couldn't see any evidence that people were doing co-production to try and solve these community problems. How you got mutual aid everywhere, people signing up to volunteer, people, playing music off their balconies. And, there was a lot of community action, but not much that was brought into not much support for community response to COVID itself. And so we sort of suggested that, the other thing people like is a list. So we've got a list. So there's a diagram and a list and also numbers. So I also had 6 steps. People like those. Anyway, so here's four steps to emergency preparedness and response, with some sub steps. But anyway, so we were just basically trying to make the case that it's worth investing in co-production. It's worth just spending enough money to be able to bring people together, to facilitate dialogues and try to get networks that are mutually supportive and networks of trust, so that well, at the time we were writing, there was an emergency, but also for preparedness. If you have community groups, then they can help. For the travellers, some of the contact tracing was done with the help of the community groups that were already working with them. And with that in mind, you don't need to build a whole nother set of community groups. You can just use the ones that are there. But if they don't exist, so if there aren't, healthcare liaisons, or as I understand it, there used to be police liaisons in traveller communities, and I don't think those are funded anymore. But there are those kinds of setups that you could potentially support to try to make sure that the dialogue is open for when an emergency comes. You have to consciously include everybody. If you don't, then you will definitely miss out people. And there were some very obvious examples in the pandemic, not least people with chronic conditions who were just left, told to lock down and never really told when they could come out again. And obviously the travellers as well, they really felt, in some cases, they felt that they had been completely abandoned during the pandemic. And if you are going to do it, then you need to show people that they're being heard and that you're actually prepared to act on what they say. And that's not to say there's a free-for-all. People sometimes think that when we say things like this, you've got to do everything that people ask for. And that's not the case. Of course not. And actually what we've found is that although there's a real stereotype of, if you ask patients what they want, then they'll all ask for like all the services all the time to be open 24 hours and no waiting time. And actually it's completely untrue. In fact, most patients are highly conscious of the constraints, the financial constraints on the NHS, and they make enormous efforts to come up with cheap or free ways to improve things. And in fact, they're incredibly modest usually in their proposals in terms of what finances would be required. And so I think it's a real problem as well. There's a sort of, I don't know why, but there's a real feeling of like, oh, you know, if we give them an inch, they'll take a mile or something, when it's like, well, it should just be a collaboration that we're trying to improve everything for everyone. And we just agree how we're going to do that. And also, if whatever you try isn't working, then you can work together on how you can make it better. So my final slide. Well, what is it? What did we learn? This isn't really this is more like what I learned and what I'm taking forward. So there were lots of other things, but one of the things, I kind of said it already, but translation is so important in so many different ways at so many different points. And as soon as you break down, as soon as your dialogue is broken down, you've lost so much. And sometimes you don't even realize that that's what's happened, and people have kind of withdrawn from the process and you don't realize it. So, you know, maybe diagrams, maybe lists, maybe nice graphics. I don't know, people make nice videos and stuff. And I'm interested in this idea of co-production and quality. Like, what does it mean to have quality research, and how is co-production related to hierarchies of evidence? You know, there's a kind of sense that co-production sort of sits to the side of sort of research somehow, or that it's not directly entwined with what quality research should look like. And I don't know if that's right. And then, of course, this idea about equity and ethics and co-production, like why do we have to justify the costs of co-production in a research project? Shouldn't we start to get to the point where we're explaining why we're not doing it? That would be my dream. So that's the last slide. I just wanted to acknowledge my amazing team who've been fantastic throughout, especially Alicia Renedo, who's been kind of producing a lot of this work with me through the whole thing. That's it. Thank you very much.